Okay, well, thank you everybody for coming today. It's cold, but it's not that cold. But very glad you're here for Talking Public Health. And today we are privileged to have Dr. Stephanie Mazzucca-Ragan. She is an assistant professor and she got her doctorate in nutrition and policy from UNC Chapel Hill with the lousy basketball team.
For now.
It's only because got a few UNC people here. So she's assistant professor at Brown. Her research focuses on organizations and public health systems and how they adopt, implement, and sustain evidence-based strategies to promote healthy eating and physical activity and to improve public health outcomes. That is a long sentence.
Well, we got to chop.
Dr. Mazzucca-Ragan has extensive experience in applied research, program evaluation, and implementation science, and strengthening methods to conduct rigorous research. And she's published widely in peer-reviewed journals, and her work has been funded by National Cancer Institute, Centers for Disease Control and Prevention, and Bloomberg Philanthropies or Philanthropies. I haven't had any lunch.
That's okay. You should do something. Yep.
So anyway, so we're really thrilled to have you here, and I'm going to turn this over to you, and then we'll have fun with questions.
Great. Sounds good. Okay. Thank you everyone for being here today. Okay, I think this is like truly everyone who is in anywhere near the Brown School. So thank you to those of you who are here and online. Okay, and we are going to figure out, there we go. Okay, so this is what I'll cover today, starting off with a little bit of background to the health topics that I focus on, describing the work that I've done in a couple different organizations, sharing some of the work that I've done in dissemination and implementation research, which I'll use interchangeably with implementation science. Wouldn't be a WashU talk if we didn't cover that somewhere here. Yeah. And then I'll close with where I see things headed in the future. My research focuses on healthy eating and physical activity. These modifiable behaviors are associated with a number of positive outcomes like cardiovascular, immune, and mental health, cognition and sleep, and the prevention of chronic diseases like diabetes and cancer. These are complex behaviors, as you can see in these images, and there are a variety of multi-level factors that influence whether or not an individual can engage in these behaviors. We know from national surveillance data that most Americans are not meeting these guidelines. About 40% don't meet the daily dietary recommendations, and about 80% don't meet the physical activity guidelines. So these are the focus of many of our interventions and policies in public health. One important place to start when we're thinking about healthy eating and physical activity is the early years. So during the birth to 5 years old point in a child's life. Habits are being formed. And at this time, many children are spending much of their time in early care and education or ECE settings, or even shorter childcare. My work has shown that about half of a child's daily calories are consumed in childcare, and as much as 80% of their physical activity is accumulated while they're in those spaces. Childcare became a focus in public health around the same time when the field had developed a number of evidence-based strategies to improve health. And we were starting as a field to contend with how we take those and broaden the impact and reach of these interventions. And here enter D&I research, which is at the end of this translational science spectrum. D&I research gives us a paradigm and research methods to think about how we best move evidence into public health practice. I spend most of my time in the purple and gray circles right here, but certainly thinking about those later phases informs how we think about the earlier phases and how we might accelerate translation. There we go. Okay. When we're moving along that translational research or that translational science spectrum into D&I research, organizations become a really central focus because they're the primary setting in which implementation happens. They're complex and they're influenced by a number of factors that are internal to and external to an organization and related to what we're asking them to do, so that evidence-based thing. And it's also important to remember that organizations are comprised of people who work at multiple different levels, have their own sets of perspectives, motivations, goals, and expertise. And that's depicted nicely here in what's called the EPIS model. For my work, state and local public health agencies are the key implementing organizations. They provide funding and technical assistance to support those who are on the ground, the local implementers actually doing the public health implementation. So it's important that these agencies are set up well to do dissemination and implementation. And this requires two broad things that we've discussed in our Prevention Research Center. That individual staff have the skills to conduct evidence-based decision-making, and that the organization is supportive of those processes, that it's valued and incentivized by leadership, that it's written into job descriptions, and that they have time and resources dedicated to making evidence-based decisions. Most of the staff working in public health agencies aren't trained in public health, so they're showing up on day one of their job without a formal public health degree. And this means that workforce development becomes really critical to supporting public health agencies. And based on some of the work that I have led, there are relatively low ratings of those organizational supports. So we have some work to do to make sure that our public health agencies are working at their best. Okay. So I've just described two types of organizations. You might be thinking, that's kind of weird. Those are really different. What's the deal? So while they're different, they're similar in a lot of ways and they're related as part of the same public health system. So typically funding comes from the CDC and federal funders, passes through the state and local health departments to individual childcare settings who are delivering these voluntary healthy eating and physical activity programs. They have wide influence and reach. There are a lot of these organizations across the country, and they share many characteristics. Heterogeneity is the name of the game. There are huge health departments like in New York City and teeny tiny county health departments in small towns. And that influences the way that we position our work. So when we're thinking about healthy eating and physical activity, going into a small health department where one person is covering all of chronic disease programming, we have to situate our work a little bit differently. So same thing when we're thinking about childcare. They have hierarchical structures, so leaders overseeing some sort of classroom teacher or health educator, something like that. They have really, really high turnover, and they're doing a lot with very little financial resources. So that leads me to my overarching research questions. How can we enhance organizations' delivery of evidence-based programs and policies and impact public health? Here I'm thinking there about what are the characteristics of organizations that are important, and what do we do about that? What are the D&I strategies that are effective for supporting organizations? And then kind of thinking about more as my nerdy side will show, what are the methods, measures, and resources that we need as researchers to make sure that our work is high quality and impactful? Okay, so moving into some of the work that I've done in childcare, the very first public health research study that I worked on was to update and modify an existing observation of childcare environments to a self-report version that's completed by classroom directors or childcare directors and classroom teachers. It's a long name. The Environment and Policy Assessment and Observation, or the EPAO, is the only comprehensive measure of the eating and physical activity environments in childcare. It assesses the provisions, practices, and policies within childcare. There we're thinking mostly about organization policies that influence healthy eating and physical activity behaviors of young children. And in this study, we collected 4 days of observational data in 50 centers in North Carolina, multiple days of reporting from classroom directors or center directors and classroom teachers, and objective measures of physical activity using accelerometry. So in this study, I got paid to watch children play, and that was really a great start to public health. We were able to refine the observation and the self-report and develop really parsimonious guidelines about how to use these tools based on the reliability and validity evidence that we found. And after that, I led a number of iterations of this observation and self-report, thinking about different types of childcare settings, family childcare homes, and infant and toddler classrooms that are quite different than the 3 to 5-year-old classrooms that the initial center observation was based on. And as part of an update to incorporate the latest and greatest research evidence, I created a number of tools to promote the uptake of this observation and self-report. I created training and certification materials, data scoring and entry tools that are freely available online and have really supported the use of these materials. An example of how we use that data to think about what to do in childcare is here in a study I led focused on understanding the natural variation in physical activity across a preschooler's day and where we might identify some opportunities to move the needle. So linking that observation data to the accelerometry data, we examined how much time children were spending in different standard classroom activities that are listed on the x-axis. And this is really the bird's eye view that we can then kind of think about the intensity of activity in each of those classroom activities. I can get really in the weeds, Rodrigo, if you want to talk about the accelerometry later offline, there's some really interesting things in there. So here we learned that children were not surprisingly accumulating most of their MBPA during outdoor time, but they were spending way more time than we would have expected in what's called center time, which is kind of like either informal playtime or scenarios where children are directed around stations within a classroom. And we can think about their shifting the distribution from a little bit less sedentary time to either light or MBPA and having a profound impact on how much activity children are accumulating in classrooms. We saw that TV or screen time was pretty infrequent, so that was pleasing to see. Hopefully that has stayed the same over time. And in our analyses, the differences in the proportion of sedentary behavior and MBPA were significant by classroom type. So we've used the observation and self-report in a number of other studies to identify important characteristics of childcare organizations, and other research groups in the US and internationally have used the EPAO. The original version of that observation was created as part of the knapsack intervention for childcare settings, which is an evidence-based program grounded in social cognitive theory to improve the eating and physical activity environments in ECE settings. The program is bundled into several focus areas like child nutrition and outdoor play and learning, and takes a continuous quality improvement approach where childcare staff assess their current practice compared to standard best practices, plan for and implement changes to the areas they want to focus on, assess where they are, and then kind of rinse and repeat in multiple cycles. The current version of the intervention is called Go Knapsack, and it's a web-based adaptation of what was originally kind of like a pen and paper intervention. As part of this adaptation, we updated all the best practices, and I led the child nutrition section, and the work that we had done that I showed in the previous slides fed into some of the other program areas. We tested that adaptation in North Carolina and found it to be successful in improving EPAO scores. Both the original and the updated digital adaptation of this program have been diffused widely, sort of in a grassroots way initially, into public health practice. Since 2017, when Go Knapsack was released, more than 13,000 childcare programs have used it, primarily supported by CDC funding. And the original version was recognized as a model early learning program in the Let's Move campaign. So all of my work contributed to Go Knapsack's impact and success, and I work with my UNC colleagues, their basketball team, be darned, still on this program. My little one is really good at sharing her germs, so I'm still on the tail end of a cold, as I feel like is everyone. Okay. So then thinking one step up about the public health agencies, part of that public health system, naturally, the first thing I got to do when I came to WashU was a measurement development project. You can see kind of where my nerdy interests are. And we took what had been used as a measure of organizational supports in surveys that had been conducted by the Prevention Research Center to tinker with, refine, reduce a little bit this measure of organizational supports. So the final measure that we identified had 22 items across 6 subscales that are shown in this figure. I'm not a psychometrician, but I kind of played one on TV for this one, but used data that we had collected from local health department staff to fit a confirmatory factor analysis. And we saw acceptable fit. So you'd want to see the RMSEA above like 0.06 or 0.08 and the CFI above 0.9 or 0.95. I meant below. RMSEA should be low. Sorry, I misspoke there. And we saw significant associations between these subscales and the number of interventions, evidence-based interventions that these health departments were delivering. So we showed some nice construct validity there. And then when we're working in public health agencies, we're not just trying to get them to do evidence-based things, but we also come across scenarios where ineffective programs are being implemented as well, and effective programs are being stopped. And we call this misimplementation, including both of those two scenarios. Both of them are concerning. Our work is mostly focused on the continuing ineffective programs side of misimplementation. It leads to a waste of resources, and it's influenced by a number of modifiable factors, whereas the termination piece is kind of like you lost funding, and that's really the kind of key driver of that type of misimplementation. It's pretty common in health departments as much as, or as high as 30% in some of our work. So it was, a really interesting opportunity to say, hey, what's going on here? And as part of a project, a larger grant to build an agent-based model, we did some interviews with state health departments that I analyzed to understand what actually is an ineffective program in their mind and why do these programs continue to be implemented. And we saw 4 main reasons for that. The first being the idea of inertia. So it's hard to make pivots during the course of a grant. A program in motion will stay in motion. People didn't want to make changes to programming in terms of capacity. They would potentially lose out on employees' salary. And so then, losing their personnel resources in the department. They also expressed a desire to do something. So there was this desire to act and implement something, even if that something wasn't evidence-based, that it felt good to know you were doing something. And then last, one of the biggest things that came up was the idea of partnership maintenance. So especially in scenarios where these health departments were implementing something that a partner was interested in or had, kickstarted, they were really hesitant to squash a partner's excitement, jeopardize those relationships that they had worked really hard to build. So kind of pulling in that partnership piece, one of the ways that we can support public health agencies is through academic health department partnerships, which are a type of community academic partnership that provide mutual benefits to teaching, research, and practice. We as academicians can improve the relevance of our research and teaching, and public health practitioners can have access to all of our expertise in things like evidence-based decision-making. They range from being, really informal, just interpersonal relationships, all the way up to formalized relationships where there are signed memoranda of understanding, shared staff, things like that. And they're pretty common. More than 60% of local health departments report being involved with a college or a university in our latest profile of local health departments. And they're associated with improved public health practice. So there have been case reports of these partnerships and kind of like individual reflections, but there haven't been studies to systematically understand what are these partnerships and how do we support them. We're working to fill the gaps in those we're working to fill those gaps in knowledge about academic health departments with a grant that I'm leading, funded by NCI. It's an R37, which went in as a 5-year R01 and was scored highly and converted into an early career merit award. It's a program that NCI began a few years ago. So towards the end of the 5-year program or the 5-year grant, I can apply through a non-competitive process for an additional 2 years of funding to build on the initial scope of work. The grant has 2 aims. First, to deepen our understanding of academic health department partnerships through a mixed methods study that will inform a trial phase that we're entering later this year, in which we'll test strategies primarily tailored to facilitation to strengthen partnerships and improve the implementation of cancer prevention and control programs. So including the healthy eating and physical activity, but also broadening to things like tobacco screening or tobacco cessation and cancer screening. Our practice partner for this work is the Public Health Foundation. They run a nationwide network, a learning collaborative of AHD partnerships. And we have a number of great WashU investigators, WashU staff, and then Dr. Paul Irwin at UAB, who has led a lot of the work initially conceptualizing these partnerships. One of the things that those partnerships do often is workforce development. And an example of that is the scale-up work that we recently did for the evidence-based public health course. That is the crown jewel of the Brownson family. They developed it in 1997 and have been running it since. The course is a mini MPH and takes participants through 10 modules, from things like community assessment to identifying a public health program, choosing strategies, planning for, implementing, evaluating, and then disseminating findings. I've been a part of the instruction team since 2021, and it's been a really nice way to interface with public health practitioners, to infuse my research into my teaching, and then have my teaching infuse into my research. So this version of the course was run a little bit differently. It was a partnership between 4 CDC-funded prevention research centers, their corresponding public health training centers, and state and local public health departments. In case you're not familiar with those organizations, the PRCs are the academics. The public health training centers bring expertise in instructional design and kind of the administrative coordinating of training. And then the public health departments link to those who participate in the course. Each partnership delivered the course independently, and we did a multi-method evaluation to understand if it worked. So we did interviews with partnership members to understand what the benefits were of this training model and some of the determinants. We found that leveraging the unique strengths of each partnership really maximized the effectiveness and the efficiency of delivering the course this way, and that having both that academic and practice perspective was really important from the perspective of participants. Interestingly, we had a number of people tell us about some spin-off projects that they had started. So this, partnering on this course kickstarted another project that they were excited to work on together. And then this course has really nice, materials that have been developed carefully over, decades. So it makes it a really nice turnkey operation for folks. That was a nice facilitator. We had funding from CDC, which seemed really important. And then, of course, communication between members of the partnership. And just a snapshot of some of the individual level changes that we saw. So surveying the participants of the course before and after. We assessed 14 skills related to evidence-based decision-making, but I'm showing the 2 that increased the most and the 2 that increased the smallest amount, though all 14 increased significantly as a result of going through the course. The 2 that increased the most related to using economic evaluation for decision-making and then using action planning. I teach that module, so I was really excited to see that. And then the 2 that increased the least might be a little bit of a ceiling effect. Those were the highest at baseline. But overall, I think these were really promising results to us to think about how we might modify the delivery of this course. Okay. So then the thing that got me to come to WashU, besides this delightful weather, was D&I research. And one of the papers that I led when I got here as a postdoc that came out of the Wonder Group was a designs review to understand how we're setting up our D&I research to test dissemination and implementation strategies. And there are a couple things about D&I research. This is like really preaching to the choir, but just highlighting why we were motivated to do this review. thinking about the difference in our D&I research questions that are focused on the uptake and sustainment of evidence-based programs into clinical and public health practice. There's a prioritization on external validity. So we're thinking about the heterogeneity of settings and all those nice, messy differences in context that are front and center. We like to acknowledge those and not sweep those under the rug. We think about community partner preferences differently. So there's an ethical justification for providing some sort of treatment when we have an evidence-based thing in our hand. And while not unique to D&I, D&I is inherently multi-level, so that creates a little bit of complexity when we're thinking about design. And we included in this sample, we reviewed protocols that were testing a D&I strategy, had some sort of evidence-based program or policy with it, tested against some sort of comparison group, and included at least one quantitative measure. This is a snapshot of one of the tables. The point is it's supposed to be small and illegible because each of these rows is a different study design used in the sample. So you can see there were just like so many different study designs. They're grouped in this table by individual level designs with insight, between site, and then within and between site designs. Couple things to note here. I was surprised to see any individually randomized or individual level designs, but here they were. The most common designs were cluster randomized trials about half of our sample. And then less common, but more common within the newer papers in our sample were things like stepped wedge and other rollout designs. So thinking about how we might use more flexible designs. Some other characteristics of the studies, about half cited a theory, model, or framework. Rachel was happy to see that. Most commonly, CFER, REAIM, and a theoretical domains framework. And about 60% combined quantitative and qualitative measures, though we didn't code specifically for mixed measures or mixed methods. That was a little hard to tell from protocols. And the research was primarily set in high-income countries. So the US, Canada, the Netherlands, and Australia were the four most common. And I'll spare you my soapbox of cluster randomized designs, but I think one of the important things that I took away from this study was that taking stock of where D&I studies were at this time is really important to see where we need to go. Cluster randomized designs are not going anywhere, but they shouldn't necessarily be our default. They should be well justified and should match the goals of our study. And I see some snickers in the audience, so I know I have.
I'm joining you on that.
Yes. So, but there are other designs, and everything needs to make sense for your study. And it's important to be transparent in your decision making. That was just so clear from this group of studies. We used this review to update a toolkit for DIRC and a couple other centers, so we continue to use this review to support others at WashU. An example of one of these alternate designs is my current N of 1 trial, which enrolled its last of 3 participants in November of 2023. Of course, I'm kidding. I wanted to sneak some pictures of my little Josie in here from first eating some solid foods where it was a full body adventure up until some peaches that were apparently not so great. So another paper that came out of the WashU group was a review that I led in the annual review of public health. And this paper described opportunities for implementation research focused on preventing chronic diseases in community settings. And this was really like anything that wasn't a clinical setting. We focused on the 6 types of community settings that can support chronic disease prevention, shown in the white part of this figure. We reviewed literature in each of the sections, identified exemplary implementation studies, and tried to understand what was needed for future research in this type of area. And I'll note that we started with work in each of these individual settings, but there was a lot of multi-sectoral work, which was really exciting to see. Some of the opportunities with these sorts of settings are that they're the organizations of daily life. They're responsible for providing and shaping the basic needs, health behaviors, and social interactions of individuals. And these are where people are spending their time compared to healthcare and interfacing with public health agencies. And especially when we're thinking about addressing the social determinants of health, these are really, really key organizations. We saw common challenges with researchers forming relationships with these organizations within the context of grant work, and really wide variation in the willingness and capacity to implement these largely voluntary programs. So thinking about how to overcome some of those challenges within D&I research is important. And the paper set up a chapter that I led in the most recent D&I textbook. And one area where I think this could go, the private sector really didn't come up so much in one of the community settings. There just wasn't that much to review, but I think as we're looking towards the future, that'll be a really important setting for us to consider. Okay, so some of the other D&I studies that I have been a part of work to understand the social networks related to giving D&I research advice. Research to operationalize the outer setting. Like, what is the outer setting? What does it mean? How do we measure it? And what existing measures, thinking about the social determinants of health, are available and useful to us? And then two, thinking about dissemination specifically. First, a review of dissemination frameworks and a latent class analysis of a survey completed by state legislators so we could help think about tailoring and audience segmentation to improve communication. I've had several leadership positions in different parts of the WashU community where I've been able to consult with and help other researchers across WashU who are interested in integrating D&I science into some of their work. And with that, I'll think about where I'm headed. So if you were at the last Talking Public Health seminar last week, you heard a little bit about this study. We didn't plan to be back to back, but it was actually a pretty nice setup for us. So my colleague Pasquale Rumo at NYU is my NPI on this project that's funded through Bloomberg and UIC. And what we're doing here is assessing a lot of information about the United States' first added sugar warning label legislation. We're assessing restaurant level compliance. And then more of the work that I'll be doing is focused on the qualitative portion, thinking about some of the implementation outcomes and determinants of the policies, implementation, enactment, and enforcement. So here I'm bringing in my expertise working with the local health departments who are a big player in the enforcement piece. We will also be thinking about how to learn from the strategies that are used to implement, enact, and enforce these policies so that other municipalities can learn from these sorts of policy initiatives. And I put this in the future looking section because it's a really nice example of where I see my work going, combining healthy eating, promotion, the public health system, and D&I research all together. A couple other examples of studies that I'm cooking up and thinking about how to reposition going into June submissions. Some of the work that we showed with Go Knapsack led us to believe that the strategies that are being used are really good to get people to use the program initially, but then there's some drop off. So Sarah is shaking her head, thinking about sustainability and thinking about sustainability really from the beginning and how can that be addressed on the front end. Along with my UNC colleagues, we're thinking about how to improve the equity in the use of Go Knapsack, and that's going to be a fun time repositioning that work. And then we're going to build on the agent-based model that I talked about a little bit related to misimplementation. The initial model was focused on state health department work. And so we'll move this into local level misimplementation to really explore those external factors, thinking a lot about partnerships there. So revisiting those research questions, how can we enhance organizations to deliver evidence-based things? We can take stock of what's happening in those organizations and understand what's important, and then integrate that into programs and policies to improve health. And then thinking about my contributions as an academic nerd, thinking about observations, measures, and how we set up our study designs and research to be most useful. I could not do this without many individuals, of course. Too many to list on this slide. I think my parents joined on Zoom, which is so nice. So thanks, Mom and Dad. And of course, to my Prevention Research Center and Brown School colleagues. So with that, I will take questions. And that's all I got. Stunned to silence.
Let Rodrigo.
Go ahead, Rodrigo.
Well, it's fascinating, so much work, and you really summarized everything so well. Thank you so much. You have me thinking about some of the questions I've been asking colleagues in the work I'm doing with folks outside the public health domain, transportation, planners,
Oh, yeah.
architects. So what's your advice if you are trying to, and this is a very, very honest question because I need that advice. What's your advice if we want to expand the D&I contribution outside public health, the public health domain, with, engaging folks in zoning, planning, transportation, where all the frameworks and all the sort of the concepts are a little far-fetched at this stage now.
Yes, and I really appreciate that these like talking public health questions have become like consultations, like let's all figure out how to solve all of our research problems. So a couple of things come to mind. I don't know that it's, I know that they are, you are kind of operating in, like parallel worlds, but there is a lot of overlap. And I think finding those synergies is really key to kind of like reframing and reorienting. Kind of like when we think about talking with people that don't share our political views, like finding where there is common ground and where we can, like where what they're doing and what we're doing are kind of working along the same path, which is a little Pollyanna, but I think can at least be a good starting point to building relationships with people. And then you can kind of like start to chip away at the more contentious things. Some of the other things that I'm thinking about, maybe like pulling from examples of like the health and all policies things where, there are really very clear and successful examples of where, like municipal governments have been supporting health and, like really good things have come of that. So maybe like trying to like tempt people with competition, like, don't you want to be as good as this sort of a place? So kind of, I think those are the first two things that come to mind, at least in terms of like starting the conversation. I'm sure there's more once you kind of like dig down a little bit, but to start off, that's where I think.
Thank you, Steph.
So first, thanks for a great talk. I learned something new, even though I thought I knew a lot about your work. So that's always great. Come to a seminar.
Wait, what did you learn that's new?
Some of the
peaches.
Early childhood.
Oh, the peaches. Yeah, that's fair. That's fair.
I feel maybe this is that's postdoc work, but I feel like the designs you could be done again. This field has developed so quickly, 7-8 years later. So I have two questions about that.
Okay, so I'll preface that question. I did ask you that 2 years ago, and you told me we could wait. So I think it's time now. But you did at that point tell me that we could wait.
I forgot.
That's okay.
So the questions were first, kind of knowing what this field well. If you were doing it, what are some of the things you would look for, or what might be different? Like 8 years later than it was.
Okay. So I think I've been hanging around with all of you for too long because I think there's a lot that we could think about with like all of the simulation work. I mean, that's like a whole giant bucket of work that's not represented in those protocols. And I think as I was thinking about it, like situating some of the work across the different things that D&I does. So it's not all about testing like a dissemination or an implementation strategy, that there are lots of other things that are going on. That would make for a very unwieldy review, but I think that's an important thing to think about is how we're positioning the different D&I activities that we need to accomplish and what are the study designs that are being used or should be used at those different points.
And the other question, that sort of comment about the randomized design
Yes.
being very common, and I agree with you that you need to kind of match the research question with the strongest design possible. But the countervailing force on that is study sections
Yes.
default to randomized design.
Yes.
So how do you take work that's not in randomized design and sell it to other audiences, especially with researchers who almost default to the randomized world?
Yeah, that is, I thought that would be easier to do in some study sections versus others, and it turns out it's not. They're all, I think, at least in my read of things right now, still thinking about things pretty similarly. So where I have seen people be successful, and I'm sure others have experience with this too, but it's thinking about, if it's like a natural experiment, that's a pretty easy, like you just simply cannot randomize. And then other things, thinking about like with some of the stepped wedge stuff, really explaining what the benefits are from, like an efficiency, like a sample size perspective, or some of the other ways, like really just being upfront about this is what you're getting with internal validity, this is what you're getting for external validity, and this is why we're choosing to put a premium on one or the other. I think as long as you could just really clearly, transparently say, this is what we're doing and head it off at the beginning, because it seems like it's coming up in conversations, like in the discussion of grants, and then things maybe go off the rails where if like you had controlled the narrative as the applicant, you could probably have gotten away with a little bit more. But that's kind of like my anecdata there. Yeah.
No, go ahead.
Okay, just maybe follow up on that. First of all, great presentation,
Thanks.
especially the photos. I got
Thanks.
one.
I have more photos than I know what to do with if you ever need them.
My question, maybe a follow up on that. I know there's been a lot of conversations now about the target trial emulation and whether that is something we can use more to try to convince study sections
Oh,
on whether we can use observational data.
okay. Can you say that is, I'm unfamiliar with that. Target trial emulation?
Yeah, it's the new kind of in the block and
Okay.
epidemiology, so I'm not sure.
Okay.
Yeah.
Yep.
So I was wondering if you heard of it. So
No.
we can talk about it later. It's
Yeah.
coming mostly from the causal inference lab at Harvard.
Oh,
and
okay.
It's mostly about how can we use data, observational data, to actually emulate
Yes.
RCTs, and it seems like it's
Ooh.
getting a lot of
Yeah.
attention. So I wasn't sure, do you think that's a path we can go forward?
I think so. And I think that would be really interesting to think about, especially when we're really trying to be lean with our research operations. How can we use what we already have? And that might, that might sell well at a study section where, like you're being efficient and mindful of limited resources. Okay, sorry, I'm gonna go to Matt first.
You wait.
Matt has a question about the peaches.
It's not about the beaches.
Darn.
But, thank you. This was a really great tour of your work. I appreciate it. I had a question about the sort of the early childhood diet and activity thread.
Yeah.
In your work, and it had me thinking about universal pre-K.
Yeah.
Which would fit squarely within, that age range. And I guess I'm wondering two questions. In places where universal pre-K has been adopted, have they baked in requirements around some of the diet and activity guidelines that you would support? That's part one. And then part two, if you imagine a future where like 5 or 10 years out, everybody has universal pre-K, it's in every state, what would it take to get us from where we are now to having what you need baked into those policies?
Oh, gosh, I love that question. That's such like an optimistic question for how I'm feeling right now. Okay, so I'm not familiar with a lot of the specifics of the studies looking at universal pre-K and what they include and don't include, but from my limited knowledge, typically there's more they're able to integrate more of the healthy eating standards really easily because those are tied to like food procurement and reimbursement, and you can really like track that very easily for a childcare operation. So I've seen that probably come up more. The physical activity side of things probably less, but I mean not for lack of trying, just that it's I think a little bit of a more nebulous area for childcare. And then to your second question about what it would take, workforce development. And I didn't say that, but that's like really the thread that runs through a lot of my work. It's that, childcare teachers they're not trained in healthy eating and physical activity. That's not really like their primary job. So a lot of the work that we had done was focused on professional development for classroom teachers, directors, to think about how we can make changes at the classroom level and how then the directors can set up the organizational policies and expectations when we're thinking about kind of like infusing physical activity into the classroom. A lot of it will also focus not on just like the provision of food and opportunities for activity, but thinking about the interpersonal dynamics when we think about like child feeding practices and kind of like the parenting practices, that translates really nicely into caregiver practices in childcare. So it's really like, I think both the how to structure your classroom and also how to interact with children in a way, because sometimes unintentionally teachers can like, get a child talking on the playground and then they're like, really like attached to the teacher and then that lowers their physical activity. So there are kind of like, there are a few quirks to being a childcare teacher supporting physical activity where it's sometimes a little bit counterintuitive. So those are the things that I think about, but mostly workforce development. And then with that, I think training or the funding that would be needed for that and the technical assistance. So kind of like thinking at the agency and up level, like there would need to be, whole offices created to support universal pre-K and all of the different things that childcare would like to integrate besides healthy eating and physical activity.
Thanks.
Yep.
You tried to skip over it.
Oh, no.
You
No.
featured in a few different places some of your great methods and measurement development, instrument development work. Thinking about like training the next generation of public health scholars.
Oh, yeah.
Like what would you say to them about why it's important to spend part of your career on not just new framework development, but actual instrument development, which we don't do a great job of?
That is not a question that I had thought would come up, Doug. Okay, well, a couple things. So to me, the devil is always in the details. So for me, like taking all of the nice theories, models, frameworks that we have, like sometimes those are a little squishy. I don't really know what to do with those. But when you put an observation or a survey in front of me, like that gives me a real clear understanding of what those constructs are, what they're not, and then how they're operating within an organization. So I think for me, as I was learning, I don't have an MPH. So when I came here as a postdoc, like that was my crash course in what is public health really, from like, the governmental public health side of things. So it really gave me a deep understanding of what these organizations are up against. It gave me a really rich understanding of the context. So that was I think a real benefit for my career as I think about them, like what are the next steps? What do we need to do? Kind of sequencing my work. So I think for like personally, that was a real benefit. I'm trying to think of other things. There are tons of things. It's also so fun. Like you get an answer, like you run a model and you get a thing. And like, that is just really lovely. So it's very rewarding. And I think it makes us, well, I think it also makes you appreciate how hard it is to have a good measure. Gosh, that's really a nice benefit. And then I think it makes you think carefully about what methods and measures you choose in your research if you really understand kind of like what's going on under the hood. I'm sure there are other things, but those are the things that come to mind.
That's great. Thanks.
Can I ask another question?
Sure.
So I'll ask you to put a public health advocate hat.
Oh, okay.
So your early work made me think about the value of the partnership between universities and local organizations and local departments, and which makes me think about what is unfolding in the world right now. So as an advocate for public health, well, how would you frame the value of those partnerships for somebody who is not, embedded in the department or in the university? So we can sort of tell other folks how important those partnerships are.
Yeah, that's, it's a funny time to be doing research in like with academics and local and state health departments, and then the two combined. So it's like a little, a little
Yeah.
demoralizing sometimes right now. But thinking about the framing of, the value, um, I think like framing, my first question is like framing for whom? And I see Matt and Shar, so like I have to put on my health communications hat. But like, so am I talking to like, a red state legislator? Am I talking to like my mom and dad? Am I talking to, my
Which you are, by the way.
like like everyone's rogue uncle at the Thanksgiving table. So like, is there a particular
Yeah.
part of that you were thinking about, or kind of just like everything?
Yeah.
Okay, so I think then I would probably, well, this is a tough one, Rodrigo, and you can see I haven't cracked it yet. But I think, because it's easy, I think, for me to tell the story of academics and health departments separately. That's where I've kind of been thinking about, but I haven't been thinking as much about like talking about the value of these partnerships. Because I think where I struggle with that is the way that different people value evidence and evidence-based decision making. So I don't know that I have a good answer for you, but those are that's what I think what I bump up against is understanding what people think about the activities that these sorts of partnerships do. But trying to probably show the benefit to people, or the economic benefit of like to an area. People get really excited about the stories, like some of the work that we did in Poplar Bluff. It was like a project that was focused on community gardening, and people were so excited about it. And it was like a small project, but it got like people together and excited. And it was, like a partnered project. So I think people can really like link in on the stories and that kind of side of things. I'm not sure that's the best answer, but again, at least a starting point. But I'm curious to hear others in the room as well.
I'm not gonna try to answer that question. I'm gonna ask another question. But it's, given what you were saying about it's hard to work in these sectors, and then thinking about in the review, how you didn't see a lot of work that was partnered with, private sector. And so how do you think about, especially thinking about food provision, like how do you think about those private sector partnerships, especially when we're thinking about how probably everywhere is not going to be New York City and wanting to put up
Right. Yeah.
those sugar warnings. Yeah, how do you think about them?
Yeah, and I've been thinking about that, like in the work so Rachel and I are on a project together that's working with Schnooks to put out some of the food as medicine, like prescription sorts of initiatives. And they've been a really great thought partner, and a really great leader in this area. So my default is to think about places and organizations like that are interested in serving their community because they're proud of being in St. Louis. They're proud of serving the St. Louis community in the ways that they can. So I think I think a lot of those like food as medicine type things, there's a lot to unpack with that, but at least making the link to the private sector and understanding how we can make the business case to Schnooks that this is good for them, with some of the work that you and the business school people are doing, like that's really important. But then thinking about kind of like, they do feel social responsibility. And so that's not something that was surprising to me, like how front and center that is. So thinking about just like learning, going in with an open mind and understanding the organization for what they are, what they have to offer, and kind of where they would like to see things moving.